Hello everyone, now let us discuss about 2023 changes in the coding guidelines of nursing facility services. Coming to 2023 changes in the nursing facility CPTs. The first change is the CPT 99318 has been deleted. The 99318, it involves evaluation and management of a patient involving an annual nursing facility assessment that has been deleted. To report, see subsequent nursing facility care CPTs 99307, 308, 309 and 310. So 99318 has been deleted. That is one change. The second is all the codes for initial nursing facility, subsequent nursing facility care, nursing facility discharge services, all these CPTs from 99304 to 99316, they have been revised. The initial and the subsequent nursing facilities CPTs have been revised in such that MDM and or time are considered as the prime governing factors for the code selection. Previously, history and examination were also the key components for the selection of code. But from 2023, MDM is considered as the prime governing factor, and also time. Whenever time is considered, time, and whenever MDM is considered, MDM. MDM and or time are considered as the prime governing factors for the code selection. And when it comes to nursing facility discharge services, they have been revised such that code selection is based on the total time on the day of discharge management face-to-face encounter. These services require the face-to-face encounter with the patient or caregiver or family. Physician must have a face-to-face encounter for the specified time, and the code selection is based upon the time on the date of discharge that has been given by face-to-face encounter. Now coming to the general principles of nursing facility services. The following codes are used to report evaluation and management services to patients in nursing facilities and skilled nursing facilities. SNF and NF, nursing facilities and skilled nursing facilities. These codes should also be used to report evaluation and management services provided to a patient in psychiatric residential treatment centers. Apart from nursing facilities, these codes are also applicable for the E&M services provided to a patient in the psychiatric residential treatment centers and immediate care facilities for individuals with intellectual disabilities. This is an important point. These codes should also be used to report evaluation and management services provided to the patient in a psychiatric residential treatment center and immediate care facility for the individuals with intellectual disabilities. Regulations pertaining to the care of nursing facility residents govern the nature and minimum frequency of assessments and visits. These regulations also govern who may perform the initial comprehensive visit. And these services are performed by the principal physician and other qualified healthcare professionals overseeing the care of the patient in the facility. The principal physician is sometimes referred to as admitting physician and is the physician who oversees the patient's care as opposed to other physicians or other qualified healthcare professionals who may be furnishing the specialty care. Admitting physician is the primary physician who will oversee the patient's care. And these services are also performed by physicians or other qualified healthcare professionals in the role of a specialist, performing a consultation or concurrent care. Even those physicians can report the nursing facility services who perform a consultation or a concurrent care. Modifiers may be required to identify the role of individual performing the service. And two major subcategories of nursing facility services are recognized as initial nursing facility care and subsequent nursing facility care. Both categories, both subcategories, they apply to major two subcategories. One more subcategory is there, that is nursing facility discharge services. And when it comes to these major two subcategories, nursing facility care and subsequent nursing facility care, initial nursing facility care and subsequent nursing facility care, both subcategories apply to new or established patients. Whether it is new patient or established patient, there is only one code. For initial nursing facility, there is separate code, and for subsequent nursing facility, there is separate code. And these types of care, example, skilled nursing facility and nursing facility care, are reported with the same codes. Place of service codes should be reported to specify the type of facility and where the service is performed. This is also important. The place of service codes should be reported to specify the type of facility and where the service is performed. When selecting a level of medical decision making for nursing facility services, the number and complexity of problems addressed at the encounter is considered. And for this determination, a high level MDM type specific for initial nursing facility care by the principal physician or other qualified healthcare professional is recognized by this type. The important point is we have discussed that from 2023, MDM is considered as the prime governing factor for selection of level. And whenever MDM is considered for selecting a level of MDM for nursing facility services, the number and complexity of problems addressed at the encounter is considered. We all know that MDM has three key factors: number and complexity of presenting problems, amount of data to be reviewed, and the risk of morbidity and mortality. These are the three key factors. So whenever it comes, especially for nursing facility services, when selecting a level of medical decision making for nursing facility services, the number and complexity of the problems, the first key factor of MDM, is considered for the selection of level of MDM. Based upon the level of MDM, you will select the appropriate code. So for this determination, a high level MDM type, which is specific to initial nursing facility care by the principal physician or other qualified healthcare professional, is recognized by this type. So here are some of the examples for a high level MDM. Multiple comorbidities requiring intensive management. So patient must be having multiple morbidities requiring intensive management. The next is a set of conditions, syndromes or functional impairments that are likely to require frequent medication changes or other treatment changes and or re-evaluations. The next is patient is at a risk of worsening medical status, including the behavior, and risk for readmission to a hospital. The next is definitions and requirements related to the amount and complexity of data to be reviewed and analyzed, and the risk of complications and or morbidity or mortality of the patient management are unchanged. Now coming to various nursing facility services. The first one is initial nursing facility care, the next is subsequent nursing facility care, and finally nursing facility discharge services. Now coming to initial nursing facility, coming to new and established patient. For the new and established patient, when a patient is admitted to nursing facility, the course of an encounter in another site of service, for example, hospital emergency department or office visit, these services in the initial stay may be separately reported. So whenever we are reporting initial nursing service, the first point is whether the patient is new or established. There are same codes for new patient and for an established patient. The second point is whenever the patient is admitted to a nursing facility during the course of an encounter in another site of service. That is, first patient visits to emergency department or office visits, then gets admitted to nursing facility. In these circumstances, other services, it can be either emergency department or office visit, can be reported separately along with 25 modifier. Modifier 25 may be added to the other evaluation management service to indicate a significant separately identifiable service by the same physician or other qualified healthcare professional was performed on the same date. In the case when the services in a separate site are reported and the initial nursing facility service is a consultation service performed by the same physician or other qualified healthcare professional and are reported on the same day. Do not report 99252, 99253, 254 and 255 or initial care services. This is important point. When the services in a separate site are reported and the initial nursing facility service is considered as a consultation, not as a reason for admission. Initial nursing facility care service is considered as a consultation service performed. In that case, you should not report the inpatient consultation codes which come under 992522, 99255. Nor you should report the initial nursing facility care services. You should not report inpatient consultation or initial nursing CPTs. The consultant reports the subsequent nursing facility care 99307, 99308, 99309 and 310 for the second service on the same date. There are two scenarios here. The first one is patient is admitted after a course of encounter in the another site of service. In this case, you may report the services in the initial service may be reported separately and 25 modifier may be added. Second case is that is you can report an initial service and an emergency department or office visit. Here the patient is admitted. So no issue. By giving 25 modifier to the other E&M service, you can report both services. The second case is the service when in the case when services in a separate site are reported and the initial nursing facility care services is a consultation service. Consultation service performed by same physician or other qualified healthcare professional reported on the same day. In order to consider whenever initial nursing facility service is performed as a consultation service, you should report subsequent nursing facility care codes for the second service. You should not report the inpatient consultation codes nor the initial nursing facility codes. Now, hospital inpatient or observation discharge services performed on the same date of nursing facility admission or readmission may be reported separately. Hospital inpatient or observation discharge services performed on the same day. Discharge services here. Patient is discharged from inpatient setting and is readmitted or admitted to a nursing facility. Then these two services can be reported separately. For a patient discharged from inpatient or observation status on the same date of nursing facility admission or readmission, the hospital or observation discharge services may be reported with the codes 99238 and 99239 as appropriate. This we will discuss when we discuss about inpatient codes. And for a patient admitted and discharged from the hospital inpatient or observation status on the same day, you need to see 99304 to 99306 series. And the time related to hospital inpatient or observation care service may not be used for the code selection of any nursing facility service. This is important because these two are separately identifiable services. The time related to hospital inpatient or observation care services may not be used for the code selection of any nursing facility service. Initial nursing facility care codes 99304, 305 and 306 may be used once per admission. Initial nursing facility care code should be used once per admission per physician or other qualified healthcare professional, regardless of the length of the stay. For once per admission, it does not depend upon the length of the stay. Only you should report once per one admission per physician or other qualified healthcare professional. They may use these to bill initial comprehensive visit performed by principal physician or other qualified healthcare professional. The initial nursing facility care services can be used for the initial comprehensive visits performed by either principal physician or other qualified health professional. We know that there are two types of nursing facilities in general: skilled nursing facility and nursing facility. Skilled nursing facility initial comprehensive visits must be performed by physician only. This is important point. Skilled nursing facility initial comprehensive visit must be performed by physician only. Whereas a qualified healthcare professional may report initial comprehensive nursing facility visits for nursing facility level care patients. In case of nursing facility, qualified healthcare professional may report initial comprehensive nursing facility visits. But when it comes to skilled nursing facility, initial comprehensive visits must be performed by physician only. And this too, in case of nursing facility, a qualified healthcare professional may report initial comprehensive nursing facility visits if they are allowed by state law or regulation. And the principal physician or other qualified healthcare professional may work with others. This principal physician or other qualified healthcare professional may work with others who may not always be in the same group but are overseeing the overall medical care of the patient in order to provide timely care of the patient. They are overseeing the patient, but they may not be in the same group. In such case, the medically necessary assessments conducted by these professionals prior to the initial comprehensive visit are reported using subsequent care codes. The principal physician or other qualified healthcare professional may work with others who may not always be in the same group, but they are overseeing the medical care of the patient, and these medically necessary assessments conducted by these professionals prior to the initial comprehensive visit are reported using the subsequent care codes that come under the category 993072 to 99310. The next is initial services by other physicians or other qualified healthcare professionals who are performing consultations. Here, these physicians are performing consultations and they are providing the initial services. Patient is directly presenting and an initial service is performed by other physicians or other qualified healthcare professionals who are performing consultations. They can either report initial nursing facility care codes that are 99304 to 306 or inpatient or observation consultation codes 992522 to 99255. This is not dependent upon the principal care professional's completion of the initial comprehensive services first. This is not dependent upon the principal care professional. Principal care professional is nothing but the admitting physician. This is not dependent upon the admitting physician's completion of the initial comprehensive services first. Whenever the initial services are performed by other physicians or other qualified professionals who are performing consultations, they can be reported by initial service codes or consultation codes depending upon the service rendered. And this is not dependent upon the completion of initial comprehensive service visits by the admitting physician. Whenever the admitting physician is performing the initial comprehensive service, then you can report initial services. Even though the physician is not performing any initial comprehensive service visits and the initial services are provided by other physicians, then also you can report initial or inpatient or observation consultation codes. This is a little tricky. In simple words, it is not mandatory to perform an initial comprehensive service first. Initial services can be reported before the completion of initial comprehensive service visits also, depending upon the circumstance. An initial service may be reported when the patient has not received any face-to-face professional service. What is initial service? This is the definition. An initial service may be reported when the patient has not received any face-to-face professional service from the physician or other qualified healthcare professional, or another physician or other qualified healthcare professional of the exact same specialty and subspecialty who belong to the same group practice during the stay. When advanced practice nurses or physician assistants are working with the physicians, they are considered as working in the exact same specialty and subspecialty as a physician. And an initial service may also be reported if the patient is a new patient as defined by the evaluation and management guidelines. For reporting initial nursing facility care, transitions between skilled nursing facility level of the care and nursing facility level of the care do not constitute a new stay. Whenever a person is transferred from skilled nursing facility level to a nursing facility level care, they do not constitute a new stay. This is a guideline. That is, you should not consider that person as a new patient or that admission as a new stay. Whenever the patient is getting transferred from initial nursing facility level care and to a nursing facility level of care. For reporting the initial nursing facility care codes, transitions between skilled nursing facility level of care and nursing facility level of care do not constitute a new stay. Now coming to the various CPTs of initial nursing facility care, 99304, 99305 and 99306 are the three CPTs. All these three are revised in the 2023. Here MDM is taken as a governing factor, MDM and time. So whenever MDM is considered, in order to report 99304, either for straightforward or low MDM, you can report 99304. And for moderate MDM, you can report 99305. And for high MDM, you can report 99306. Now here you can see the code description, 99304. Initial nursing facility care per day for the evaluation and management of a patient which requires a medically appropriate history and or examination, medically appropriate only, and a straightforward or low level of medical decision making is required for reporting 99304. When using total time on the date of encounter for the code selection, 25 minutes must be met or exceeded. 25 minutes, whenever time is considered, 25 minutes must be met or exceeded. Whenever MDM is considered, straightforward or low level of MDM can be reported by 99304. Next CPT 99305. Initial nursing facility care per day for the evaluation and management of a patient which requires a medically appropriate history and or examination and a moderate level of MDM, medical decision making. And when using total time on the date of the encounter for code selection, 35 minutes must be met or exceeded. For 99304, it is 25 minutes. For 99305, it is 35 minutes. Whenever time is considered for the code selection. Whenever MDM is considered for reporting 99305, the level is moderate level. The next is 99306. Initial nursing facility care per day for the evaluation and management of a patient which requires a medically appropriate history and or examination and a high level of MDM. And when using total time on the date of encounter for code selection, 45 minutes must be met or exceeded in order to report 99306. And the for services 60 minutes or longer, use prolonged service codes 99418. Now here we'll see an example for high level of MDM 99306. This is an example for high level of MDM Initial Nursing Facility Care Service 99306. A 78 age is a factor. 78 female with calf pain admitted for weakness for a skilled nursing facility following a recent stroke. She has left lower extremity 6 by 10 dull and constant pain that started 2 days ago and is associated with edema and erythema. Internist was asked to evaluate as a consultant at the request of rehab physician. Here you can see 4 elements from the HPI, though it is not mandatory now for the selection of code. Next, coming to past surgical history, recent stroke, hypertension, high lipid profile on Lipter, aspirin and lisinopril. So, comorbidities are there. Quit the smoking on the day of her hospital admission 6 days ago. Mother has a risk of stroke. Coming to ROS, all the systems were reviewed and otherwise negative without further pertinent positives or negatives. Next, coming to examination, BP is normal 120 by 80. Temperature is normal, well appearing. 9 organ systems were examined. HENT is normal, eyes are normal, CV normal, respiratory normal, GI normal, psychiatry normal, lymphatic normal, neurological, mild residual weakness in left leg and arm following the stroke. Cranial nerves are intact, skin, edema, warmth, redness on the left leg. Consistent with cellulitis marked with the skin marker. Coming to the labs, the WBC count is 13K. Venous Doppler report has also been reviewed and there was no clot. Here you can consider one point for the documenting of lab in the complexity of data decision making. Venous Doppler is reviewed. That also can be considered as one point. Coming to the conclusion, impression is cellulitis. Cellulitis, this is a new problem. Further workup planned under the number of diagnoses for medical decision making. It gains 4 points. It is a new problem and it requires further workup and the patient has multiple comorbidities and is on prescription drug management. Recent history of stroke. All these points must be taken into consideration. The plan is start antibiotics, review case details and rehab physician, vitals stable except for fever, initial oral antibiotics, check the rate and X-ray of the rect to verify no fracture from falling after stroke. Physician reviewed the old records, no X-ray done during the acute care stay in the hospital. Physician has reviewed old records. 2 points for documenting discussion of case with another healthcare provider and reviewing the old record. Continue the workup and follow-up lab in the AM. Here, this is considered as a high risk. Patient recently had stroke and cellulitis is considered. One important thing is patient does not have diabetes. If the patient would have been diabetic, further workup would have been planned. Though patient does not have diabetes due to the history of recent stroke, hypertension, HLP and prescription drug management. All these points are considered and the medical decision making goes to high. A new problem, further workup planned. New problem with systemic effects. cellulitis has a new problem with systemic effect. Considered the patient having multiple comorbidities. This can be considered as high level of MDM. So 99306 must be reported for this case. Now coming to subsequent nursing facility care CPTs. There are 4 CPTs in subsequent nursing facility care: 99307, 99308, 99309 and 99310. This requires straightforward MDM. 99307 requires straightforward MDM and 99308 requires low MDM. 99309 requires moderate MDM and 99310 requires high MDM. Coming to the code description, 99307 subsequent nursing facility care per day for the evaluation and management of a patient which requires a medically appropriate history and or examination and a straightforward, as we have discussed earlier. 99307 requires straightforward MDM and 10 minutes of time must be met or exceeded when using total time on the date of encounter for code selection. Either it must require straightforward MDM or 10 minutes must be met or exceeded. Now coming to 99308, it is a subsequent nursing facility care per day for the evaluation and management of a patient which requires a medically appropriate history and or examination and a low level of medical decision making. In order to report 99308, you require low level of medical decision making, and whenever time is considered for the code selection, 15 minutes must be met or exceeded. Let us see an example. Mr. Blancos is the resident of Shades due to his Alzheimer's disease. The patient's condition is stable and has good compliance with the medication. Here, patient has a chronic condition, that is Alzheimer's, but the patient's condition is stable. So this comes under low of medical decision making and he has good compliance for medication. So the appropriate code is 99308 for this scenario. Subsequent nursing facility care per day for E&M of a patient with low level of medical decision making. Next code is 99309. Subsequent nursing facility care per day for the evaluation and management of a patient which requires a medically appropriate history and or examination and a moderate level. In order to report 99309, you need to have moderate level of medical decision making. When using the total time on the date of the encounter for the code selection, 30 minutes must be met or exceeded. 99309 requires a moderate level of MDM, or whenever time is considered, 30 minutes must be met or exceeded. Now let us see an example for 99309. The chief complaint is established patient for depression. Coming to HPI, she is 80-year-old obese white female living at nursing home. She has history of major depression, stable, generalized anxiety disorder, still symptomatic. Patient has 2 chronic conditions and the other condition, anxiety, is symptomatic. Complaints of nervousness, increased worries, misses her husband, dementia. Along with depression, generalized anxiety, patient also has dementia of Alzheimer's type and is stable. There are no suicidal or homicidal intentions. ROS, no weight loss, no fever, no chills. Positive for hearing loss, positive for incontinence, GI incontinence. Psychiatry, positive for depression and anxiety. Pulse is 70. Temperature is 98.6 and the BP is 136/69. Appearance is calm, cooperative, obese. Muscle strength normal. Gait and station, sitting in wheelchair. Though content, no helplessness. Suicidal or homicidal intentions are not there. Thought process is simplistic. Associations blocking. Abnormal psychotic symptoms, none. There are no abnormal psychotic symptoms. Insight and judgment are poor. Mood is fair and worried. Orientation 1 to 1%. Labs, creatinine level is 1.1, BUN is 21 and INR is 2.1. Reviewed attending physician note, skin rash on face, He advised observation. Now it is resolved. Coming to the assessment, patient has major depressive disorder in remission, stable, continues on lepro, generalized anxiety disorder, continue clonazepam, dementia of Alzheimer's type, continue supportive therapy. Patient has 3 chronic conditions. So whenever 2 stable chronic conditions are there and the patient is on prescription drug management, you can go for moderate level of MDA. So this is an example for 99309. Now coming to 99310. Subsequent nursing facility care per day for the evaluation and management of a patient which requires a medically appropriate history and examination and a high level of MDM. In order to report 99310, high level of MDM is required, and whenever total time is used for the selection of code, 45 minutes must be met or exceeded. And for the services 60 minutes or longer, use prolonged services code 99418. Now coming to nursing facility discharge services. The nursing facility discharge management codes are to be used to report total duration of time spent by physician or other qualified healthcare professional for the final nursing facility discharge of the patient. They are time-based codes. Codes include as appropriate final examination of the patient, discussion of the nursing facility stay, even if the time spent on that day is not continuous. Instructions are given for continuing care to all relevant caregivers and preparations of discharge records, prescriptions and referral forms are done. These services, the revision is, these services require a face-to-face encounter with patient or family or caregiver that may be performed on a date prior to the date of patient leaves the facility. And the code selection is based upon the total time spent on the day of the discharge management face-to-face encounter. There are 2 codes for nursing facility discharge services, 99315 and 99316. 99315 requires 30 minutes of less face-to-face time, whereas 99316 requires 30 minutes, more than 30 minutes of face-to-face time spent by physician. Here you can see the 2 codes 99315 and 316. 99315, the description is nursing facility discharge management 30 minutes or less total time on the date of encounter. 99316 requires nursing facility discharge management more than 30 minutes total time on the date of encounter. For less than 30 minutes you need to report 99315, and for more than 30 minutes you need to report 99316. Let us see an example. 78 female with calf pain admitted to weakness for SNF following a recent stroke. Patient was diagnosed with cellulitis. Course of oral antibiotics have been started. Medications reviewed. Patient has past surgical history of recent stroke. Comorbidities are hypertension, HLP on Lipter, aspirin and nisropin. Cellulitis was healing well and patient was planned for discharge. Physician spent 45 minutes of time with the patient and counseled her regarding the medication compliance and advised to complete the course of antibiotics. Refer discharge note for further information. Here the total time spent face to face is 45 minutes. So the appropriate code is 99316. Nursing facility discharge management more than 30 minutes total time on the date of encounter. Thank you for watching. Please subscribe for further videos on medical coding and CPC training.